I'll be talking about the advances in the medical management of chronic sinusitis. In the first half, I will go over an overview of the management of chronic sinusitis with nasal polyposis, and then in the second half, I'll tell you our approach, our research, as led by Dr. Blyer at my institution, looking at different way of controlling inflammation through controlling one of the chemicals involved in the inflammation. For those of you who don't know Boston or who have not been to Boston, this is my hospital here, the Massachusetts Eye and Ear. So the reason we're talking about advances in the medical management of chronic sinusitis, when I did my training from 90 until 95, endoscopic sinus surgery in the United States was at its infancy. At that time, we thought that endoscopic sinus surgery can cure all cases of chronic sinusitis. It was thought that it's mainly an anatomic problem, do surgery on that OMC region, and then all patients will be cured. But then we realized that actually it's more of an inflammation, more than an issue of, anatomy plays a role, infection plays a role, but it's mainly inflammation. And that many cases you do surgery on, and then after 6 months, they'll be back to square one. There are patients, for reasons we don't understand, severe disease, you do surgery once on them, and they are good for life, and there are others, as I said, you see them a few months later, and as if you have not done much on them. And therefore, I see surgery more as an adjunct to medical therapy. This is what I tell my patients. I tell them, we'll do surgery. Chances are you will still need to continue medical therapy after surgery. The aims of the surgery, it can improve the symptoms, it can decrease the disease load, but it can also improve the delivery of the medications to the target sites. So the other issue with chronic sinusitis is that it's not a single, do you have the line? Yeah. Very faint light. It is not a single problem. It can be genetics, it can be allergy, it can be impaired mucociliary clearance, it can be infection, environmental factors, impaired epithelial defense, immune dysfunction. So it's a multitude of variables that all lead to chronic sinusitis. And to just think of a simplistic model does not work. There are different pathways of inflammation. The most common in the nasal polyposis cases are the Th2 inflammation. But then you can also see, IL-33, IL-25 working through the innate immunity on the left side of the screen, which then lead to the innate cells can become Th2 cells, and then they can produce IL-13, IL-5, IL-4, leading to the other, products which can lead to inflammation. And then on the right half of the screen, you can see the infectious part, the easier to control part. So it is a multiple pathways, but those that are most difficult to cure are those who fall in this center here, where these two pathways meet with these inflammatory mediators and then leading to the disease process that we know. This is the same slide that Professor Falkins showed. What I like about this is that the upper part of the slide, those with IL-22 and so on, these are in my mind at least easier to treat, easier to cure than the lower part. The lower part are the most frustrating. The lower part are the reason there is so much research happening in biologics, and there is so much investment and technology being poured into it, because the lower part, the IL-5, the IgE, that pathway with severe asthma. These are patients who are very morbid, severe asthma, severe polyps. You do surgery on, they fail. And these are the ones that we need to help mainly with the newer medical approaches. In the past, when I did my training, these were the options. And these are still good options. And many patients, the majority of our patients actually, are in one of these options. Steroids, topical, is the mainstay of therapy. Sometimes we give short courses of oral steroids, antihistamines for those who have allergy, antibiotics for those that there is superimposed infection or we think there is a biofilm and so on. immunotherapy for patients who have documented allergy. But don't forget about the importance of saline irrigation. I think it is as important as the medications. And I tell my patients, you have to do it at least every day, consistently, and we tell them to use distilled or pre-boiled water. And at least at my institution, many patients are on the budesonide rinses, even though this is not FDA approved for sinusitis, but we believe it's more effective than the commercially available steroid nasal sprays. But it is cumbersome. Some patients don't like it because of the way they have to position their heads. I believe because the dose is not controlled, there could be a slightly higher risk for glaucoma. So I tell the patients to make sure that they see their ophthalmologist every 6 months to a year so that they can check the intraocular pressure to be sure that they don't develop glaucoma. Now, we moved, as the previous speaker said, we moved from a phenotype-based treatment to an endotype-based treatment, or we are trying to move, I should say, trying to move to an endotype-based treatment. So in the past, we used to say this patient has allergic rhinitis, this patient has infectious chronic sinusitis, this patient has chronic sinusitis with nasal polyposis, and then we will treat them accordingly. Now we are looking more at the inflammatory mediators, at the IgE, at the aspirin exacerbated respiratory disease, at leukotrienes, at IL-4, IL-5, IL-13, IL-17, and then I'll show you our research with the P glycoproteins, which is our focus. So I did this study with my colleague back in 2005, using Montelukast, oral, very cheap, 1 pill a day. These are patients who were on steroid nasal sprays with persistent nasal polyposis before surgery, and then we added Montelukast for 3 months. And then we tested them. And as you can see, the reason I'm showing this, because I will show you later data about the biologics, and unless you can improve on that outcome, the question becomes, is it worth spending all this money on these biologics? The biologics in the United States, they cost around $30,000 US a year. So unless you can significantly improve the outcome, it could be hard to justify the cost. So here, as you can see, if you're looking at symptoms, adding leukotriene to these patients, those with allergy symptoms, around 80% of them improved over what they were doing with their topical steroids, and around 60% if they had non-allergic rhinitis. And then we looked at the tissue eosinophils on those patients who allowed us to biopsy the nasal polyps in the office pre-treatment and then post-treatment, and looking at the score of their tissue eosinophilia. Again, you see significant decrease in their tissue eosinophilia with just adding Montelukast. The response was more dramatic in the allergic group, but it was also noted on the non-allergic group. At that time, we did not do more in-depth research, so we did not look at the overlap between these two groups, as in the slide I showed you before. So both groups, the allergic and non-allergic, could be having a Th2 response with IL-5 related response, even though clinically they are behaving differently. Now, for those who have aspirin exacerbated respiratory disease, since the first paper was published from the Scripps Clinic, we are offering it more and more to our patients. Most patients don't have to be admitted. The target is 325 milligrams BID, but sometimes some patients will need to go up to 650 milligrams BID. So I will share with you one of our patients. So you can see the pre-op and pre-treatment CAT scan. You can see the patient had pansinusitis with nasal polyposis. We did endoscopic sinus surgery, and then we put the patient on a regimen of aspirin desensitization combined with xyluten, which is a leukotriene inhibitor, as I said, and as well as the surgery. And what you can see, upper one is the right nasal cavity, right sinus cavities. Left one is the left nasal cavity, lower one. And you can see the patient did very well. Again, you see the ethmoid mucosa is very healthy. The maxillary antrostomy and the maxillary mucosa is healthy. The sphenoid is open. So we think that the main advantage here was doing the aspirin desensitization, adding it to the conventional therapy, adding it to the endoscopic sinus surgery and the xyluten. But you know, the prevailing wisdom is patients need to have sinus surgery before you can start the aspirin desensitization. This patient refused surgery. So she said, let's try, so I sent her to the allergy immunology team, and they said, let's try just doing the aspirin desensitization without surgery. And as you can see, this is on the left side is the pre-treatment CAT scan. On the right side, you see still images of the upper one is the left nasal cavity, right one is the lower one is the right nasal cavity, and you can see her disease is very well controlled, markedly improved without surgery. So at times, I'm not saying that every patient should have aspirin desensitization without surgery. I think it's better if they have large polyps, a high volume load, is to do surgery before. But at times, patients can do well without surgery, as evidenced by this case. Next is the anti-IgE antibody, Mepolizumab, and it is in a subset of patients, those who have documented elevated serum IgEs, documented allergens, with severe asthma, they do very well. It is injection. It is every 2 to 4 weeks. It is very expensive, but it is approved for those with significant asthma. There are no medications as of now that are indicated for nasal polyposis. So as of now, no company was willing to, has conducted, some are doing it now, has conducted studies so that they can get FDA approval for nasal polyposis. So most of these are actually approved for severe asthma. And this is a classical patient, multiple previous surgery. The patient has recurrent nasal polyposis, very severe asthma, and you can see his disease. So we did revision surgery on him, and now he is on anti-IgE, and you can see how nice his cavities are. So again, not every patient does like this. Obviously, I'm showing you the best cases. So these are the cases that did the best. Next is, we realized that IL-5 is a big player in Th2 inflammation, because it is very critical in recruiting and stimulating and activating eosinophils. The one which is more available now is Mepolizumab, and it blocks the IL-5 receptor, and the aim is to decrease the tissue eosinophilia. The paper, the original paper was published in 2011. I am aware that there are more studies happening now, both in the US and in Europe. But when I look at the outcome, at least in this paper, I am not very impressed. Yes, 12 out of 20 patients did well, but these are pre-selected patients, and yet only 12 out of 20 did well. Only 1 out of 10 on the placebo. So it makes you wonder, is it worth all the money? This is a patient of ours who has severe asthma. Again, the indication for using this medication was not the nasal polyposis. The indication for using the medication was the severe asthma. As a benefit, as a byproduct, their polyposis can improve as well. So this is, on the left side, you see the pre-treatment, while on the right side, you see right nasal endoscopy showing post-treatment. So there are still some polyposis in the frontal recess. The ethmoid lining still looks mildly polypoid. But overall, if you can maintain this patient in this condition, you don't have to revise the surgery. You don't have to have more surgery performed on this patient. But this is rare outcome. I have maybe 10 patients on this medication. I'm happy with half of them. The other half, I have not seen that much benefit, even though this is a proven tissue eosinophilia by biopsy at the time of the endoscopic sinus surgery. Still, the benefit, the result is not as impressive as you would like them to. Dupilumab is a more promising treatment because it blocks both IL-4 and IL-13. And IL-13 is very important in multiple of the end pathways leading to goblet cell hyperplasia, basophil, the cell membrane, and so on. This paper was published in 2016, looking at the outcome looking at the outcome. So when you look in there, the authors started with 60 patients. Already 9 were lost. What happened to these 9? Were they failures or just lost? I don't know. But then if you look at the remaining 51 patients, yes, overall, the primary outcome of decreasing the polyp score improved. SNOT 22 scores improved. Their smell improved. But then you look at how much SNOT scores improved, 18. I know that the minimum clinically important difference is 9 for this SNOT 22 to become relevant. Here it is 18. But still, if you think about it, if you ask the patients still have symptoms. So patients still have symptoms, and there is always this question: how effective? How much are you adding to the existing treatment in terms of controlling their sinus disease and their nasal polyposis? This led us to think of it differently, and this research is led by Dr. Blyer in my department, saying, can we block multiple mediators at once through the P-glycoprotein pathway? So P-glycoprotein is present in the respiratory epithelium in many organs, in many parts of the body, but it is also present in the sinus epithelia, in the maxillary and in the ethmoid epithelia. And what it does, it helps transport the inflammatory mediators, these exosomes. So it helps transport them into the tissue, into the sinus cavities, leading to the inflammation, IL-5, TSLP, IL-6, and the granulocyte monocyte colony stimulating factor. And then we know that this is overexpressed in patients with chronic sinusitis. And therefore, there is overactivity, there is over-release of these mediators. So the question becomes, and this is happening in the ethmoid and maxillary. So the question becomes, if we block this P-glycoprotein, how much can we help these patients by preventing the release of these inflammatory mediators? So there are 3 generations of increasing potency. We decided to go with the first generation. It's commercially available. It is very inexpensive. You're talking about few dollars a month instead of $2,000 or $3,000 a month. And we chose the dose of 80 milligram POTID because this was indicated for cluster headache. So we knew it is safe. We knew it will not cause any serious side effects. So we decided to start with that dose. So this is a double-blind, placebo-controlled, randomized trial. Patients were asked to be off any form of steroids for 4 weeks, be it oral or be it topical. Almost done. Okay. And then we started them on verapamil, as we said, placebo versus treatment arms. And then we looked, the primary outcome was the SNOT 22, but then we looked at secondary outcome, the Lund-Kennedy score and the Lund-Mackay score as far as the CT and endoscopy scores. And this is how we recruited them. We ended up with 10 patients in the treatment arm and 10 patients in the placebo arm. And this is what you expect for the minimum change in SNOT to be clinically relevant. Again, placebo, we did not notice much difference. But on those who are treated with verapamil, we noticed benefit within 2 weeks. And this benefit continued to progress through week 8. And that was in SNOT 22 score as well in the visual analogs score. And you see the benefit progresses through week 8. And then if we looked at the particular domain, smell and congestion improved the most, while things like drainage did not improve as much and sneezing did not improve as much. And then when we looked at their CT scores, there was significant improvement in the treatment arm compared to the placebo arm. When we looked at their nasal polyposis, endoscopy, there was a significant benefit by week 4, but then we lost that benefit by week 8. So there was a relapse. And then, so this is a classical patient. This is a quick video. So this is a classical patient. You see the improvement in the subjective symptoms. You see CT pre and then CT post treatment. And then you look at the endoscopy findings. You saw it at baseline. You'll see it now at week 2. You start to see some improvement. Then you will see more improvement at week 4, and then more improvement at week 8. This is not universal. This is not the entire 10 patients, but it is impressive that these are patients off steroids. The only treatment is verapamil. They have extensive nasal polyposis despite previous surgery, and then you can see the degree of improvement over this 8-week trial of therapy. And then we thought this last slide.
I got the message that I have to stop you.
I know. Last slide is that we found out that BMI is a big factor. So now we are looking at a higher dose. We are looking at topical versus systemic. In conclusion, verapamil, we think of it as promising for the treatment of chronic sinusitis with nasal polyposis. We think 80 milligram TID is sub-therapeutic. We are looking at different dosage now. We are looking for, what our data, it supports the role of P-glycoprotein in the pathogenesis of chronic sinusitis. In summary, biologics are very promising, but as of now, we have still not being able to identify biomarkers that can help us select patients for treatment, predict response, and then monitor success. In summary, so I still rely on the main treatments. If they fail, I add leukotriene inhibitors. If they fail and they have significant asthma, extensive polyposis, then I start thinking of biologics, be it IgE disease, then it is anti-IgE, be it Samter Triad, aspirin desensitization, and then there is also a role for anti-IL-5, anti-IL-13, anti-IL-4, and we think there is a role for P-glycoprotein inhibitors. Thank you.